Hi everyone, Dr. Pillay with CME Travel Academy. 2026 is coming up on us, and American Diabetes Association has changed their diabetes care guidelines. We want to help you keep up at one of our in-person conferences that we have coming up. Join us in 2026. Let's get right to the changes. In 2026, there's earlier use of CGM or continuous glucose monitoring in patients, not just those patients that need insulin therapy. There's also a lot of focus on using medications based on the patient's comorbid conditions and also the patients that are at risk for developing some of these comorbid conditions. There's earlier emphasis on combination therapy to achieve these goals. And then, of course, we're going to talk about expanding the focus of these medications beyond just glycemic control. So what we're trying to do is have a people-centered approach or person-centered approach rather than just based on guidelines alone. In terms of diabetes classification, there's a lot of confusion about type 1 versus type 2 because there's a lot of clinical overlap and uncertainty. So we're going to go through an algorithmic approach on how to make sure that you're classifying your patients correctly and, of course, managing those patients appropriately. We'll also talk about the antibody testing that's needed to be able to help you diagnose these patients. In terms of CGM goals, we also are going to focus a little bit on the A1C versus using fructosamine in those patients that the A1C is not reliable and how that correlates to the average glucose reading. As we use CGM data more appropriately, we want to also look at what is the acceptable guidelines in terms of what percent of the time should they be in range, how much hyperglycemia is allowable and how much hypoglycemia is acceptable. So we'll give you some guidelines that the ADA has set out for us in terms of being able to interpret the data that we get back from these agents. Of course, as we use CGM data more often, there's a lot of things that interfere. Our patients are telling us all the time that their data from the CGM doesn't always match what they're seeing when they do a finger prick. So what kind of things affect that, such as Tylenol, vitamin C? These are things that patients take on a regular basis. Anemia versus erythrocytosis, how do these things affect the CGM data? This is also an important part of what we need to look at. And of course, in pharmacotherapy, what agents should we use to affect ASCVD reduction? We want to use GLP-1 agonists, when to use statins, and how to add on to statin therapy to get to LDL goal. What to do when patients are intolerant of statins, such as using PCSK9 agents or bempedoic acid. And then, of course, in terms of obesity management, using diet and exercise and nutritionist therapy, but also how to use pharmacotherapy, what agents have how much effective weight loss, and then, of course, when to decide between metabolic surgery versus bariatric surgery. We'll also talk about the roles for CKD in terms of using SGLT2 inhibitors as well as GLP-1 agonists, especially in the advanced CKD patients to prevent hypoglycemia. In fact, oftentimes those agents are preferred instead of insulin. In heart failure patients, not just SGLT2 inhibitors, but also the new data that shows use of GLP-1 agonists and the dual agents, the GIP, GLP-1 agonists. And then for those liver disease patients, or MASH and MASLD patients, not only using agents such as GLP-1 agonists in those patients that are obese, but also when to consider using pioglitazone or the dual agents in combination therapy to help patients out. And then the incorporation of the FIB-4 score to decide who should be the patients that stay with primary care and who has to be referred to specialty care. We're going to address all of these agents to look at the agents that we need to take care of our patients, not only to prevent comorbidities, but also to manage the comorbid conditions they already have. So come join us in 2026 at one of our upcoming conferences. In March, we're going to be going to Las Vegas. We're also going to be going to New Orleans. In May, we're going to go to San Diego. In July, we'll be in Disney World in Orlando, Florida. And then October, we're going to be going to New York City as well as Las Vegas. All of our conferences provide topics including cardiology topics, pulmonary topics, ethics, endocrine, psychiatry, and neurology. We're going to be talking about lots of different topics that are going to be pertinent to your practice of care of patients. So join us in 2026. Let us travel and learn with you. Come join CME Travel Academy. Thank you again.